let Dr. Mbuthia share what she has to share with us. Thank you.
All righty, so hopefully my slides are showing. I have no conflicts of interest. I do have some strong opinions when it comes to vaccine myths. So if they are expressed, they are my own, and they don't represent either the Queen's Medical Center or the Hawaii Department of Health. Any use of a vaccine brand name is just for educational purposes only, and it doesn't represent any commercial bias. Really, this is the learning objective that I hope you take away is that you feel more confident and comfortable addressing just a few more of the many questions that come up from either parents, patients, family members, or friends who are not anti-vaccine, but really belong to what we call the movable middle. So they're vaccine hesitant. I include up here a picture. This was a recent issue cover of The Lancet, which just further enforces why vaccine education for clinicians is going to continue to be important. It states that the destruction that Kennedy has wrought in 1 year might take generations to repair, and there is little hope for U.S. health and science while he remains at the helm. So that was the cover of The Lancet. So I'm just going to jump right into it. Start off. Really, really common question that's been around for a while. So this predates, kind of concerns raised during COVID, but why so many shots at one time? Will it be too much for my baby's immune system? Moving forward, I will refer to the vaccine schedule for childhood immunizations that we should be following as the AAP childhood immunization schedule. I may refer to the old CDC versus the new CDC as well. But the short answer is that the childhood immunization schedule is not overwhelming the immune system. Just for reference, so the number of antigens in the current childhood vaccines totaled is about 170. The old school smallpox vaccine that was used in the 1960s and early 70s had about 200 antigens. So what has happened is over time, there have been advances in science that have been able to scale down the number of vaccine antigens that are stimulating immune memory. It is focused and it is precise. So the infant immune system is constantly being exposed to new antigens. Some are going to be more dangerous than others. But when we look at the childhood vaccine schedule, especially during the first 2 years of life, it takes into account two key factors. One is the ability of the immune system to respond to the vaccine. And then two is the threat of natural infection to that young infant. So this is a screen grab that was actually presented at the December 2025 ACIP meeting by Aaron Siri, who is not a clinician, he's not a healthcare provider, he is actually an attorney who does a lot of work in suspected vaccine injury claims. And so just the visual shows it's meant to evoke some sort of emotion, but it includes in utero vaccines. It doesn't do multi or combination vaccines. It also includes influenza vaccination. But the visual is to give a certain emotion about doing too much to a baby. And then it didn't help that President Trump on his social media soon after posted this. And again, you've got a graphic that shows generic European country with only 11 injections and then 72 injections in the United States. So again, further to drive emotions about infants and the number of vaccines. And it's meant to make it seem as if the US vaccine schedule is unreasonable. Now, just for some context, those 72 injections are from birth to age 18. And it also assumes you receive every annual COVID-19 and influenza vaccine. And then when it came to the COVID-19 vaccine, it assumed that you received a 3-dose initial priming series. So again, that graphic is meant to drive certain emotions that are not a realistic representation. Meanwhile, at the same December ACIP meeting, this graphic was presented in a slide deck by Dr. Tracy Beth Hogue, and it is a graphic representing the childhood immunization schedule from Denmark. Obviously, it shows fewer needles, It's not all needles from all of, your entire childhood at one time. But the graphic also shows multiple combination vaccines. Um, I don't speak Danish, but it is representative of many of the same combination vaccines that are given in the United States recommended schedule. What it also does not show is the fact that in Denmark, they recommend RSV, pertussis, and influenza vaccines during pregnancy. So there's a lot of different ways to kind of take apart how graphics and posts like this can be very misrepresentative. And a little bit about the pediatric immune system. So a term newborn has passive immune protection to some infections from maternal IgG, but that will start waning around 4 to 5 months of age. The thymus, which is where T cells are made, in a newborn, it is big and it is ready to start building immune memory. I'm sure all of us have some kind of recollection when you first started seeing chest x-rays in the NICU, and you're like, oh my God, is that a chest mass? And then you're like, no, that's just the thymus. It starts to atrophy as we age, but I think that that's a really good representation of how important it is during the first year of life. So T cells are important for fighting viral infections. T cells are also very important in helping B cells make immune memory. So when you are born, your B cells are functional, but they lag behind a little bit and they cannot respond well to encapsulated bacteria like pneumococcal disease and Haemophilus influenza type B until you turn about 2 years old. So the first 2 years of life, the B cells, which are responsible for targeting encapsulated bacteria, are not well matured yet. The same is true for polysaccharide vaccines. There's a lag until about 2 years of age for the B cells to naturally respond well to polysaccharide vaccines and encapsulated bacteria. So the timing and frequency of vaccinations during those first 6 months of life, especially, maximize the amount of immune memory that's going to be built and circulating IgG that's going to be formed so that by the time maternal IgG, passive IgG starts waning, the infant's own immune system is reaching a really good protective level against those vaccines given at 2, 4, and 6 months of age. Also, conjugate vaccines, they tie a protein to a polysaccharide. So this is a loophole in the immune system of an infant. So those functioning T cells are ready to begin building immune memory from birth. B cells have this lag and are not well equipped to respond to encapsulated bacteria or polysaccharides. But when you conjugate protein to a polysaccharide, well, now the T cells are able to respond and loop in the B cells through CD4 helper T cells. And basically, it's a way to allow an infant's immune system in the first 2 years of life to make protective antibodies and protective memory against encapsulated bacteria like Hib or pneumococcal bacteria. So those fully functioning T cells are ready to start. And another consideration about the pediatric immune system is that things like hepatitis B, Hep B is most dangerous if an infection happens during the first year of life. And the danger is kind of what happens long term in terms of chronic hepatitis and then chronic liver disease or cancer. Hib and pneumococcal bacteria are particularly dangerous during those first 2 years of life because the infant immune system can't respond well because of B cell immaturity. So vaccination is incredibly important to protect during a window where the infant's own immune system can't respond well. And then another example is that infants are most susceptible to severe pertussis during the first year of life. So maximizing pertussis protection through both maternal vaccination in the third trimester, but then also staying on time and on target with your pertussis vaccination helps maximize protection during that first year of life. Here's another thing or another myth. So the US administers, quote, significantly more doses of childhood immunizations than its peer nations. So that quote comes from the decision memo that went to the then acting director of the CDC, January 5th, 2026. So this was specifically written in the decision memo and led to a pretty dramatic decrease in the recommended vaccines that the CDC childhood immunization schedule included. A little bit more about that timeline. So back in December, when the ACIP met, that meeting was when they changed the recommendations for the hepatitis B birth dose and only recommend it for infants born to hepatitis B positive or unknown mothers. But also something that happened in December 2025 was that President Trump issued a memorandum for the HHS Secretary and CDC Acting Director to align U.S. childhood vaccine schedule with, quote, best practices from peer-developed countries. Then in January, that was that big change that happened to the CDC's childhood immunization schedule. And that change happened without any new scientific evidence, no discussion, and it actually happened outside of the ACIP meeting. But here's the reality in terms of how the US compares to other countries. So this is a graphic from factcheck.org that looks at the number of diseases targeted in childhood vaccination schedules across 30 different countries compared to the United States. So the US was actually not an outlier in terms of the number of diseases covered in the, quote, old childhood schedule. The purple line on this image shows 3 different points in time for the US schedule. So it shows how many diseases were covered in January of 2025, which was 17. How many were covered in December of 2025, which went down to 15 because hepatitis B and COVID vaccines were now removed from the routine childhood schedule. And then it shows what happened in January of 2026, a month later. We are now on the lower end. The median number of diseases targeted in multiple other countries is around 14. And now we are below the median number of diseases protected by our vaccination routine schedule. Here's another graphic specifically comparing the US to what they considered 20 peer nations. So just a little bit of orientation. So on the far left are the list of the different countries. The United States is listed twice at the bottom. The one is our schedule as of 2024. And then the suggested schedule change that the CDC made is just below that. Now, the blocks that are in red, those represent vaccinations or targeted diseases that are mandated for school entry. And for the US, they use the example of New York State school requirements. Then the dark green boxes are vaccines that are recommended for all children according to that country's vaccination schedule. And then at the very bottom, you'll notice there are some light green boxes with a capital letter A in them. So the light green means that the vaccine based on the new CDC schedule, these vaccines are available and should be covered by health insurance under the new CDC schedule. So when you compare where the US was in 2024 to 20 peer nations, out of those 20 peer nations, all 20 recommend vaccination for DTaP, polio, Hib, pneumococcal, measles, rubella, and HPV. 19 out of 20 recommended vaccination against mumps. 18 out of 20 recommend vaccinations to get Hep B. 17 recommended rotavirus vaccination, 15 recommended meningitis vaccination, 12 recommended varicella, and 8 recommended influenza vaccination. But given the amount of change that happened, the ones that I put in blue font, those are the ones that were removed from the routinely recommended CDC schedule. So we went from being with the majority of recommendations to now being on the far end with Denmark. So some people ask, where did I find this chart? That literally is the chart in the document that was the supportive scientific evidence to make the changes. It was written by Dr. Tracy Beth Hogue and Martin Kulldorff, and it's titled Assessment of the U.S. Childhood and Adolescent Immunization Schedule Compared to Other Countries. When you read the document itself, it doesn't contextualize it in a way that shows that we were kind of with the majority, and it tends to focus on outliers. So there's, again, misrepresentation of where we actually compare to other countries. Here's another common myth. Aluminum adjuvants in vaccines are dangerous to neurodevelopment and cause autoimmune or allergic diseases. Aluminum is found in soil, water, and also in food, and it's included in infant formula. So the reason why aluminum adjuvants exist in some vaccines is because it boosts the immune system's response to the vaccine antigen. And aluminum salts have been used in vaccines since the 1930s. So this is not something new. And aluminum adjuvants are used in vaccines around the globe. In fact, a 2025 Danish study published in the Annals of Internal Medicine looked and assessed the association between cumulative exposure to aluminum from childhood vaccination and any risk for autoimmune, atopic or allergic, and neurodevelopmental disorders. So because the Danish healthcare system is kind of a nice enclosed system, they had data from 1997 to 2020, and it looked in more than 1.2 million Danish children. And they said, quote, cumulative aluminum exposure from vaccination during the first 2 years of life was not associated with increased rates of any of the 50 disorders that they assessed. So the long and short of it is aluminum adjuvants are not linked to any sort of increased risk of autoimmune, neurodevelopmental, or atopic conditions. So I just want to say thank you, Denmark. If vaccines work and your child is vaccinated, why do you care if I don't vaccinate my child? That's another kind of common sentiment that I have heard. So vaccines are not a force field. There are multiple goals of vaccination. Primarily, it's to prevent death or hospitalization. Also, vaccines can prevent severe disease, they can prevent symptomatic disease, and they can decrease the spread of disease in a community by providing herd immunity to person-to-person transmitted diseases. But even vaccinated people can still get infected after the absolute best and strongest vaccines. So smallpox and measles vaccines have a great history of being effective, but if there is a high amount of circulating virus in a community, even vaccinated people do have risk of getting the disease. However, the risk of having severe disease or death or hospitalization drops dramatically. So I love this graphic because it really highlights as the smallpox vaccination was being rolled out, there was still a lot of circulating smallpox, but this shows two young boys who are around the same age. One was vaccinated, one was unvaccinated. So both of them did have smallpox. But you can see there is a pretty remarkable difference in terms of severity of disease between these two boys. Also, I like to think that your pediatrician cares about the health and safety of your child, as do you as a parent. So when people are like, why do you care? Well, because that's what we do. But we also care about the health and safety of vulnerable groups, like newborns who are too young to receive certain vaccines, elderly and immunocompromised patients in our community. And then more specific to the state of Hawaii is the fact that our geography is not our friend when it comes to inpatient healthcare, especially for pediatrics. Those of you who are doing private practice in certain communities are probably well aware of the fact that we have some pretty low vaccination rates in some pockets of our state. So there are communities here that are actually at a pretty decent risk of certain vaccine preventable diseases if they do show up. This is just a clip. So the measles outbreak in Samoa, this is just a visual from the United Nations putting out in their media the fact that that measles outbreak claimed the lives. So at the time that they published this, there were 70 who had passed. The majority were children under deaths from measles in Samoa because of lack of herd immunity due to loss of confidence in the measles, mumps, rubella vaccine and a significant drop over several years in measles immunization. Here's another common one that comes up. There are no double-blinded placebo-controlled vaccine trials. This is something that Aaron Siri, the attorney who did present at the ACIP, this was a big part of focus of his entire presentation. So a lot of people think there were no vaccine control trials. Vaccine disinformation pushers often mean that a specific FDA filing for a specific commercially approved product used an active comparator rather than saline as a placebo. Also, they tend to exclude foundational trials of the antigen itself, and they oftentimes will exclude established trials that were done in other countries. So, what are some options to be used as the placebo or the control group in vaccine trials? So, pharmaceutical research does not require a saline placebo for a control group when looking at vaccines. Options they use and have been used for vaccine trial control groups do include saline. Probably the most common one is a liquid that differs from the vaccine by not having the antigenic content. So a key example is going to be adjuvant-only placebo. This helps control for common local side effects that are going to be due to the adjuvant. So you just take out the actual antigenic component. Everything else in that solution is the same. And so oftentimes those local side effects that are common are going to be due to the adjuvant. So you don't have a disproportionate or increased representation of local side effects in the active group in that study. Some vaccine trials will use something called an alternate vaccine or an active control. And the reason why they might use that is to provide some protective benefit for everyone who participates in that vaccine trial. A great example of this is that the cholera vaccine studies, many of them used typhoid vaccine as the control. So typhoid vaccine that was already licensed and approved. So that way, everybody who participated in the cholera vaccine studies got some benefit from their participation through some sort of immune protection. And then another placebo that is used in vaccine studies is the earlier existing version of the vaccine. And then last, use of the same vaccine, but the control group just receives it at a different point in time. But these are all different options that are absolutely valid for looking at vaccine trials and doing vaccine studies. Now, Aaron Siri, in his presentation to the ACIP, which these images are from, he really focused a lot on the hepatitis B vaccine. And so in his graphic, he was showing all these vaccines, and he lists two specific vaccines against Hep B. So Engerix and the recombinant Hep B vaccine from Merck, saying there was no control and no placebo was done. He's misrepresenting the data, and he does this fairly often. So when it comes to the hepatitis B vaccine, 1980, there was double-blinded placebo-controlled trials that were published in the New England Journal of Medicine. The placebo was aluminum adjuvant-only solution. 1984, double-blind placebo-controlled trials for Hep B vaccine in infants in Hong Kong. That study was published in The Lancet. And the study had 4 arms, and they were looking at whether there was some interference with hepatitis B vaccination versus giving H-big or the hepatitis B hyperimmune globulin if there was any interference. But they did have placebo, and some of the arms used aluminum, and then some of the arms used saline. But these infants were also followed for 24 months afterwards to see if there was any impact on the sustained immune protection and outcomes. Then by 1987, when the recombinant hepatitis B vaccine was being studied, there was an existing hepatitis B vaccine that had been studied against placebo. So again, this is kind of being able to connect the dots in the story to understand why the control group received hepatitis B vaccine versus the new recombinant hepatitis B vaccination that was being studied. And the important part of that is the fact that, well, it would have been unethical to have a control group that got no vaccination when looking at the recombinant Hep B vaccine. So when you have a current vaccine that you know is safe and that is effective, and now you're looking at either a new version of it or a broader version of it, it would be unethical to have some patients not get vaccinated at all. And this has recently become an issue within fields of vaccine research because the United States planned on funding a hepatitis B birth dose study in Guinea-Bissau, where the rate of hepatitis B infection is about 20%. So about 20% of the population there has hepatitis B. And in that study, they were going to delay administration of giving hepatitis B vaccine to newborn infants, regardless of what the maternal hepatitis B status was. So even the World Health Organization issued a statement on why this study would be considered unethical. But this was a study that was going to be funded by the United States government. Here's just a few other examples of placebo-controlled trials for multiple common vaccines. So with the polio vaccine, the original the polio vaccine field studies in 1954 did use a saline placebo. So what they did was they looked at school children and they only gave vaccine to children in a certain grade. So about 600,000 children received the Salk vaccine and over 1 million children got the saline control. And it turns out, the kids who were vaccinated didn't get polio. But polio vaccine, the original studies used a saline placebo. DTaP vaccine. So in Sweden and Italy, there were studies that were done looking at either vaccine solvent as the control, DT or DTP as the placebo. This was done in the 1980s to early 1990s. And these studies had pretty significant numbers, and they followed the children for a lengthy period of time. So just looking at one of the studies from Italy, they had over 14,000 infants that were randomized to either get DTaP, DTP, or DT, and they followed them an average of 17 months after the third dose. The pneumococcal 7 serotype conjugate vaccine, or Prevnar. So, 2001 study in Finland used hepatitis B vaccine as a placebo because, again, you have the option to use an existing vaccine that is already being widely used as a control group. And in 2000, the Northern California Kaiser study, they did use an experimental meningococcal C vaccine as placebo. Now, that's the one that the vaccine misinformation people will point to, but that is not the only study that was done. But they try to say they used one experimental vaccine to experiment on another vaccine and try to create uncertainty or discomfort. But the reality is there were other studies that looked at the original Prevnar vaccine that used different placebos. The Hib vaccine, so in 1990, it was studied against saline control in Alaska Native children. And then 1987, Finnish study compared Hib versus no vaccine. So there are multiple vaccine examples where there was a placebo, not what gets presented by certain individuals at ACIP meetings that say no placebo was used. I love this graphic because it kind of shows how the foundation of where we are today with vaccines rests on studies that were done using some saline placebo control. So it's called the saline placebo pyramid. But because of those foundational studies of either using saline or, again, inactive adjuvant only placebos, we are able to build upon our arsenal of vaccines that are available and continue to improve upon that. But also, one of the things is maximizing the benefit to participants who are in the study and provide them some protection rather than absolutely no vaccine versus the vaccine being studied. If you look at vaccine package inserts, though, it doesn't give that full history. It doesn't tie the pieces of the story together. It's only going to talk about what was used in the control group for that specific vaccine. So this is another point that Aaron Siri relies upon. He assumes people are not familiar with the history of vaccine studies. So when he makes a claim that a current vaccine was never tested against a placebo, he's misrepresenting the truth. And he will say, look at the package insert. But again, the package insert only looks at the study. It does not give a whole history of what led to the development of that vaccine. It doesn't give a 60, 70-year history. Here's another myth. Vaccine manufacturers can't be sued and have absolute immunity. They have zero liability for vaccine injuries or vaccine deaths. This is another common piece of misinformation or disinformation that gets circulated. So where does this all kind of stem from? So there was vaccine controversy in the 70s and 80s, and it surrounded whole cell pertussis vaccine. So there were concerns that whole cell pertussis vaccines triggered prolonged crying, febrile seizures, and then these hypotonic, hyporesponsive episodes. There were also claims of it being causally related to other neurologic issues like encephalopathy. So, as this vaccine controversy gained more and more traction, there were also then claims that blamed the whole cell pertussis vaccine for causing various intellectual and physical disabilities. And then in 1982, there was a documentary called DPT, Vaccine Roulette. And it showed children with disabilities, and the parents and families blamed the DTP vaccine for their child's disability. So by 1985, there were so many lawsuits against vaccine manufacturers that caused vaccine manufacturers to decrease manufacturing or to increase the price of their DTP vaccine, DPT vaccine, DTP. Oh, sorry about that typo. Well, prices went up, but also the number of pharmaceutical companies making it went down. And there were some clinicians in primary care offices that, because of the escalating price, they stopped purchasing the vaccine. And so at a congressional level, there was recognition of the fact that we cannot continue to see the decline in pertussis vaccination in our country. So 1986, Congress passed the National Childhood Vaccine Injury Act, and that established a no-fault system to compensate vaccine-injured patients. So that's just kind of the historical context to then talk about the Vaccine Injury Compensation Program. So essentially, Congress recognized that vaccines are an important part of public health, but that a very small number of people are going to be injured by vaccines. Vaccines are still a drug. They are very rare, but can happen, vaccine injuries. And that the interest of public health should not be shouldered by the small number of people who do get injured and then leaving those people without any means for compensation. So what the National Childhood Vaccine Injury Act and the Vaccine Injury Compensation Program did was it shifted compensation from the pharmaceutical companies to the federal government. So the VICP is what we call a no-fault system for parents or patients who believe that there was harm caused by a vaccine that is contained on the CDC recommended immunization schedule. Funding for VICP actually comes from an excise tax that's paid by manufacturers. So it's included in the manufacturing costs of childhood vaccines. So the VICP is important, and it actually benefits vaccine injured individuals, because if they were to go to a regular court and try to sue a vaccine company, well, one, they need to show some sort of negligence. And they also need to show that the risk of the vaccine outweighed use of the vaccine itself. Also, medical malpractice is going to be difficult to prove. So if people wanted to sue the doctor's office that administered the vaccine, if there's evidence and they were following evidence-based recommendations, well, that's not medical malpractice. So to go to a regular civil court to bring a case against a pharmaceutical company, there's a lot of burden of proof on the person who's suing the company. By having a no-fault system, it means you don't have to show negligence or product defect. So you do need to show plausible causation. Most of that is based on the published vaccine injury table, and you need to show that there are damages. This is an easier system for compensation for the plaintiff. Now, what this does is it provides limited liability for the pharmaceutical company. Also, legal discovery is very limited. So if you go through the VICP, the pharmaceutical company doesn't fall under that kind of legal discovery disclosure. Whereas if you went on a civil case, and you can tell I'm not an attorney, then the legal discovery is something that could come up. Now, the vaccine injury table itself, there is a list of potential vaccine-related injuries and the time frame for that injury to occur. The table overall is more for legal determination. And even if the scientific evidence of the injury is fairly weak, it could still be something that is on the vaccine injury table. If there's an injury that is not on the table, then the family that is putting forward this petition can present as they need to present medical evidence that they believe supports their claim of vaccine injury. But an important part of the VICP, being awarded compensation under VICP does not mean the vaccine did cause the injury. Also, attorney fees are eligible for compensation even if the petitioner is not awarded compensation. It assumes, though, that the claim was made in good faith. So by statute, attorneys representing a VICP petitioner cannot charge a contingency fee. So that would mean that, if the family gets awarded compensation, that the attorney gets a percentage of it. You can't do that when representing a petitioner under VICP. You can get compensated for your attorney fees. Now, also, there's a whole kind of formula that they use because it has to be reasonable attorney fees. But even if your claim is denied, you can still receive compensation for the attorney fees. But the attorneys cannot get a big payout. And I think that a lot of that is tied to why attorneys like Aaron Siri, who are big in vaccine injury claims, are not fans of VICP. So what vaccines are covered under VICP? So I'm not going to run through all of them, but just going to point out some important ones. So seasonal influenza is covered under VICP, but not pandemic influenza vaccine. Pneumococcal conjugate vaccines are covered, but not the pneumococcal polysaccharide vaccine, which commercially is known as Pneumovax. Because again, VICP has to do with the childhood immunization schedule. Varicella vaccine is covered, but the shingles vaccine is not because that is not on the childhood immunization schedule. VICP is also not the same as CICP, and CICP is the Countermeasure Injury Compensation Program. That is a different congressionally funded source of injury compensation. So CICP compensates for damages and lost wages tied to some sort of countermeasure against a pandemic or a biologic threat. So the COVID-19 vaccine does not get covered under VICP. COVID-19 vaccine injuries fall under CICP. Similarly, back in, what was that, 2009, the H1N1 flu vaccine was under CICP. The Mpox vaccine falls under CICP as well. But interesting fact about the VICP is that the majority of claims are from adults. So the number one claim currently compensated is for shoulder injury related to vaccine administration, or SIRVA. That is the majority of claims. SIRVA is also about how the vaccine was administered, not the vaccine immunology itself. Now, back in 2009 and 2010, there were a peak of claims that vaccines caused autism in a child. So essentially, through a lot of scientific evidence, the VICP special masters concluded vaccines do not cause autism. And then from that point forward, any submitted claims for under VICP for autism due to childhood vaccination are automatically rejected. Some good news about the VICP is that the Cures Act actually added vaccines recommended during pregnancy. So flu, COVID, RSV, and pertussis are now covered under VICP. But here's one of the things to know about VICP. So the statute of limitations is 36 months from receipt of the vaccine. And the condition has to either be severe and be present for 6 months or longer, or the vaccine-related injury is death, or the vaccine-related injury led to hospitalization, even if the condition lasts less than 6 months. I do believe that the compensation overall should be revisited to kind of align with inflation over time. But in general, the VICP is a system that is set up to help protect the families of those who are injured by the childhood vaccine schedule. So can pharmaceutical companies be sued in civil court? Yes, they actually can. A lot of people say pharmaceutical companies can't be sued, they can't be sued, they can't be sued for vaccine. So if a VICP program has not made a decision within 240 days, you can bring a case to civil court. If a petitioner rejects the final decision, so they either reject the amount, the dollar amount compensated, or they reject the decision of no compensation, you can still bring a case to civil court. Another thing too is that vaccines that are specifically recommended for like non-pregnant adults or travel-related vaccines like the yellow fever vaccine or typhoid vaccine are not covered under VICP or CICP. Shingles vaccine is not covered under either of these programs. So you can still sue pharmaceutical companies in civil court, but Aaron Siri's not going to tell you that. I think this is my last myth. It is better to get immunity through natural infection than through vaccines. Okay. No, that's not true. So a couple of reasons why it is not better to get natural infection. So one, you don't have any control over when that exposure is going to occur. If you choose vaccination, then you know when your child will start to develop immune protection. But if you rely on natural infection and exposure, you don't have any control over when that's going to occur. So other things, so it's not just like when it's going to happen, but the age at which you might get exposed. So I thought it would be timely to talk about chickenpox. So chickenpox is one of the diseases that, I mean, I had chickenpox when I was a child. My brothers had it. Chickenpox was fairly common, and chickenpox used to circulate, and you got it at a fairly young age. But we also know that chickenpox disease in older teens and adults is a more severe infection with higher risks of complications than if you had been infected earlier in your childhood. So it would have been better for you to have gotten chickenpox when you're 3 or 4 than when you're 23. Higher risk of complications if you get it as an adult. But also, if you are unvaccinated and pregnant, and then get exposed to chickenpox, you now run the risk of something called congenital varicella, which is a severe complication of chickenpox disease in a pregnant person, especially during the first 20 weeks of gestation. So again, you have no control over when you're going to get exposed to chickenpox disease. And personally, I would rather my child not get chickenpox exposure as an older teen or a young adult where they are more likely to have complications. And then some vaccine preventable diseases have no treatment or cure. So there's no treatment or cure for measles, polio, mumps, hepatitis B, tetanus. And I did put in parentheses, there is tetanus antitoxin, but the tetanus antitoxin only prevents further symptoms from developing. It doesn't reverse the tetany that already exists. The care, if you get these diseases, is supportive care, but there's no cure. Measles infection also causes something called immune amnesia. So measles virus is what we call a lymphotrophic pathogen. It infects memory B cells. Now, there are other lymphotrophic pathogens that are viral that have negative consequences on the immune cells in different ways. But measles specifically causes immune amnesia. Now, how much immune amnesia can vary. Usually it's between 10% and about 70% of immune amnesia happens following a measles viral infection. And then you've got some vaccine preventable diseases that do have some treatment or post-exposure prophylaxis, but it ain't cheap and it's not easy to get. So again, bringing it back to varicella. So varicella hyperimmunoglobulin, or VZIG, costs about $1,400 to $2,300 per vial. And for a patient whose weight is greater than 40 kilos, they need about 5 vials. So it's a weight-based dose as a hyperimmunoglobulin, and it's not easy to obtain here in Hawaii. Diphtheria antitoxin, you actually have to get that from the CDC. So again, we don't have the treatment or the potential post-exposure prophylaxis readily available. I can't just put in a prescription for you to go get it at Long's or Walgreens. It requires a lot of coordination and a lot of money in order to do that. And I don't want to say like, don't, do something because the alternative is really expensive. But when I look at this in terms of healthcare dollars, it's a lot more expensive to have to give VZIG to one pregnant person who was exposed to varicella than it probably would have been to vaccinate the entire community or town against chickenpox. Again, I've got a lot of opinions. So I know there's more vaccine myths, but in the interest of time, I want to leave some time for questions, but then also we have the poll questions for after. So I'm going to stop talking here and turn it over to whoever's in charge of running the questions.
I can launch the quiz. Okay.
Yep. Thank you. That was amazing. Folks, while you're doing the quiz, see what questions you have rolling around in the back of your head, and we will get to them after we do the quiz.
I could have made the quiz easier by just a bunch of true false, be like true or false, but really wanted to test to make sure that kind of some of these nuggets or pearls of wisdom really kind of set in. I'm going to scroll through some of the chat questions, so let me know. Oh, it looks like it was like a conversation. Oh, no, sorry, I had to go to the top.
Yeah, we had a long conversation about the VICP, and then, but there's a really good question right after that about how to talk a family member into getting their kids vaccinated. So maybe you can focus on that once we get done with the quiz.
Okay. Oh, yeah. Yeah. So an inconvenient study really, really harps on that whole placebo control thing. That's why I spent a bit of time on that one. And then you are correct that the vaccine injury compensation program to remove a vaccine from being covered, actually, it's not just a pen stroke. There's a lot more that has to go in place in order to remove one from what's currently covered. And I bet some people are glad that I don't write the pediatric MOC questions.
I was just saying they're a little bit easier than this, but I think we've had almost 4 minutes, and about half of people have submitted answers. Couple more people, maybe. All right. I think we should save some time for Glynis's question and maybe other questions if they pop up. So I would say, why don't we go ahead and end the poll and ask you, Dr. Mbuthia, if you could just go over the questions that folks didn't get right, which are a couple of them.
Yeah.
Yeah, that would be that would
So
probably be really helpful. Thanks.
So the first question has to do with children under 2 and why we can still vaccinate against encapsulated bacteria like Hib and pneumococcal invasive disease. That's because of conjugating the protein to a polysaccharide. So polysaccharide vaccines, if given to someone less than 2 years old, their immune system won't respond to it. But conjugating it to a protein now brings T cell recognition in there. So that's why that's an important difference. So you can't give a kid under the age of 2 like Pneumovax, which is a polysaccharide vaccine, but you can give them Prevnar because it's conjugated. Similarly, if anybody does travel medicine, things like typhoid are polysaccharide vaccines. That's why when you read the kind of package insert, it says you can't give it under 2, not because it's dangerous, but because the immune system won't respond to it. Everybody got the second question right. The third question, I think the few people they answered before they read all the options, but yeah, all the above can be used. And then, so the last one, so again, the statute of limitations with VICP is 36 months from receipt of vaccine. It doesn't cover all vaccines. So travel vaccines are not included, adult-only vaccines like shingles. But the key thing is that attorney fees are eligible for reimbursement. So, okay, so the question that's presented, and thank you for sharing. Thank you for sharing, kind of your own personal story. So someone whose daughter's a physical therapist and she does not believe in vaccination. She has a 4-year-old, a 20-month-old, and there's a baby on the way. And she's read articles about what vaccines have done to children that are unfavorable. So I agree with you. This is a reason to worry because not only is this a family where they do not want to vaccinate, but they have children of different age groups, and those different groups carry different risk. So if you have a 4-year-old who continues to be unvaccinated, in about a year, they will now be in school and in kindergarten and exposed to a whole lot of germs. And that's going to be an entry portal for infections in your household. Even in fully vaccinated households, usually the kid that starts kindergarten or daycare, they're bringing the germs back into the household. So that's the vector introducing it to your family. The 20-month-old is still at risk for severe outcomes from certain bacterial infections like Hib, invasive pneumococcal disease, very real. But then also that newborn baby is going to be the most vulnerable in that household. And if you have a newborn and a kindergartner in the household, you want to maximize how much you are providing protection for that newborn by not only vaccinating the baby, but also vaccinating their older sibling to decrease that child's risk of catching some of these vaccine preventable diseases. I mean, things like measles, that newborn baby's not going to be able to get vaccinated against measles, mumps, rubella, varicella until they're even 12 months old. And at a time like this, where cases of measles are running so rampant in our country that there's travel advisories about coming to the United States, I really would encourage her to reconsider her thoughts on not vaccinating her children or consider having a careful conversation. So if there are certain vaccines that she would be okay with, usually what I focus on is let's look at the vaccines that really target airway protection. So I look at things that if you get that infection, you are at great risk for airway complications or pneumonia. Then another one I look at is things that are potentially going to cause severe neurologic infection, like Hib. I am okay if a family wants to delay getting hepatitis A vaccination, or they choose not to unless they're going to travel. But one of the things about being here, if assuming that your daughter lives in Hawaii, we can all probably remember back in 2017, we had hepatitis A that was here in our community. And a lot of people were unvaccinated. A lot of adults weren't vaccinated. Hawaii is a portal for a lot of international travelers, and a lot of vaccine preventable diseases can come through. We know certain things are positive in our the sewage water testing system. So I think for so many reasons, living here in Hawaii, it particularly makes sense to try to maximize vaccination for a family with 3 relatively young children, all of whom can have complications if they were to get measles. But in particular, a school-age child and a newborn in the same household raises a lot more risk than maybe what your daughter is appreciating.
Do you have any specific strategies that are evidence-based that you could share with Glynis for like kind of convincing? Because I think a lot of what we're seeing is that facts don't necessarily cause like behavior change. And so we struggle a lot with that because for us as scientists, we're so used to facts like making us, like I discharge my febrile babies sooner because there are studies that show I can safely do that, right? In this kind of more emotion-driven decision-making process, what would be helpful that might result in her changing her mind?
So a common strategy I use from the starting point is to actually ask, what is it that you're worried about? What is it that you're concerned about? So that way I'm speaking to or about what you're concerned about, and I'm not wasting time on something that you were not even worried about. Maybe now I've made you more worried about something. And then if somebody says, I've been hearing or reading, trying to figure out what those sources of information are. So if it comes from like a Facebook moms group, and I'm not trying to discount moms, but that's a common source of misinformation, then you kind of focus on why that group is not necessarily going to be a reliable source of accurate healthcare information. And then last but not least, well, unfortunately, because of what's coming out of the, POTUS, social media, and HHS, someone may say, well, I just heard this on the news. And so that has added a new element of focused conversation. If somebody watches some of these documentaries like An Inconvenient Study, just know every documentary has an agenda. But in particular, it would be, don't look at the patients that are speaking, but look at who is there touting themselves as an expert, and then maybe start kind of teasing and untangling that. In general, in my clinical experience, to get a vaccine hesitant family to become comfortable with vaccination, the initial consult is about an hour, just talking about these concerns. So it does take time. And then the majority of times that I have gotten families to agree to vaccinate their children, it wasn't that first visit that changed their mind. It was at least 2 touch points. The first one was the conversation, and then the second one was to kind of help gain their trust and show that I'm invested in trying to help you be comfortable with whatever decision you get to. And the AAP has some wonderful resources as well. I can't say enough wonderful things about the AAP and how they've been championing countering vaccine misinformation. Okay, I think another question came in. If there's a family history of reaction to vaccine, is there a higher risk for other family members to have a reaction, or is it more of an individual situation? The second, it's more of you're talking rare idiosyncratic issues that are happening. So one of the things too is going to be, what was that reaction? And is it that the family believes that it was a vaccine reaction, or was it truly something that was, tied and demonstrated to be most likely due to the vaccine. So one example might be that one child had anaphylaxis. So very rare, happens about 1 in a million for vaccines, but it does happen. And then a parent is like, I don't want my kids to get any vaccines. Statistically speaking, the fact that you had one child in your family get anaphylaxis from a vaccine, statistically, you would be the most unlucky family to then have a second child in your same family have the same reaction from a vaccine as well. Another one that comes up is the MTHFR. That could be a whole other conversation about how that has been used to try to justify not getting vaccinated. And there is absolutely no science to support people who have that carrier gene not receiving vaccination. So in general, an adverse reaction truly to a vaccine, that is the individual's idiosyncratic reaction, and that should not be used as medical justification to not vaccinate other family members. Okay. Sorry, I'm trying to read through. So if someone has ever cared for an ailing child at any point in time from a contracted illness, yeah. I wouldn't have been convinced with what was shared today, and I'm very pro-vaccine. And I do understand. And the purpose of this talk was to really provide information for clinicians, not to talk to parents. Yeah, I mean, you could go down individual infections and talk about what things used to look like before the vaccine and how much vaccinations have changed it. But given a lot of the conversation that has shifted towards things about liability and lawsuits against pharmaceutical companies and, hey, what about the CDC schedule? I was trying to provide some really good pearls of wisdom for clinicians to help then shape how they discuss these issues with families.
Thank you. We are over time. I'm so happy to see all this enthusiastic conversation in the chat. I think if there are any more questions, I don't know if you can stay on for another moment, Dr. Mbuthia. I don't see any more questions, just mostly comments. But this was wonderful. It was so informative. The saline controlled sort of chart that you showed, I think that was super helpful because, I did suffer through watching about 85% of that film, The Inconvenient Study, which I think is a sequel to An Inconvenient Truth, which I haven't yet suffered through. But, what actually bothered me a lot about that documentary is how sort of professional it seemed, and that they had a lot of doctors with like Harvard affiliations and all these kind of like, it seemed impressive. The tone is very like scientific sounding. And so being able to debunk that kind of fake wrong science with something that is truly fact-based, I think that is actually going to be really helpful when people come to us with those specific claims, if we can gain their trust and let them, get us to a place where we can share facts with them. I think that will be very helpful. I think, the emotional part is still really, really a struggle. And even for me as like a hardcore scientist, watching people talk about what happened to their triplets and how they all suddenly became neurologically devastated in the course of one day after getting their vaccines, like it definitely tugs at your heartstrings, and it is, I can see how without the kind of training that we have and, having read the studies that we've read, that it would be really compelling to a large swath of the population. So thank you for helping us to kind of fight back. I did also throw into the chat some information, both about the VICP, like the legal stuff, and then about an upcoming short documentary from the Pediatric ID Foundation that is going to, I think, trace out the history of vaccines and all of the achievements that it has, that we've seen because of achievements and because of vaccines in public health. So maybe Summer or Morgan, you guys could link to that in the notes as well in the Echo platform.
Yeah, no, thank you so much for kind of putting all that additional information, filling in the chat for me. Really, really, really helpful.
Yeah, I'm a little bit yeah, passionate about this too. So I'm so happy to have learned from you and to be able to share some of the rabbit hole that I went down with the VICP when I did a talk a couple months ago too. So thanks everyone for joining us. Dr. Mbuthia will be back for a couple more fantastic talks in the next couple of months. So thank you so much.